Mtazamaji, ndo namna hiyo tunaanza kipindi cha Kikao kutoka ukumbi huu wa Chandari katika chuo kikuu cha Nairobi. Kikubwa siku ya leo tukiangazia saratani. Kumbukwe kwamba kila tarehe 4 mwezi Februari mwaka 2025 siku hii tunaadhimisha siku hiyo ya saratani kwa kukuhamasisha na vile vile kukueleza ni kipi hiki ambacho unafaa kukifahamu kuhusiana na saratani. Saratani ni ugonjwa ambao umekuwa mzigo kwa watu wengi na vile vile hata kwa taifa na mataifa mengine. Na siku ya leo mtazamaji, tunazamia hilo kwa kina kwa sababu tuko na wataalam na tuko na swali kwako ukiwa pale nyumbani ukitutazama. Ingia katika mitandao yetu ya kijamii pale kwenye Facebook TV47 Kenya, kwenye akaunti yetu ya X unatupata pale TV47 News, na vile vile unaweza tuma jumbe zako, tutana maswali yako, tutakuwa tunayasoma kadri muda unavyozidi kusonga. Na swali la leo ni je, mzigo wa saratani umekuathiri vipi? Je, mzigo wa saratani umekuathiri vipi? Wanakwetu wananiita Joashon Sare, siko peke yangu. Mwenzangu Sheila Chelangat yuko katika hadhira, atakuwa anazungumza nao vile vile kukuweka sawa. Wana maswali yepi, wangependa kusema kipi kuhusiana na siku hii ya kuadhimisha saratani, kikubwa kikiwa ni kuhamasisha. Na vile vile nina mwenzangu ambaye atakuwa anatambulisha wageni wetu, Linda Alela.
Asante sana. Wakwetu tunasema wananiita Linda Alela, sio eh? And yes, it's a conversation that is open. We speak both in Swahili as well as English. The bottom line is for us to understand just how deep the cancer burden is in the country. But of importance is that we want to remind you that indeed there is hope. Why I say so is because I have had a conversation with every other person that is, represented in this house or in this room today, in this auditorium, different stakeholders, and indeed in unison we all agree that there is hope. So before we get to understand where this hope comes from and what exactly then is the hope, we must discuss this. And so allow us to get to introduce the ladies and gentlemen that are seated on this side, that is the panel side, the ones that are going to help us understand some more as to where we stand as a country into this discussion of the cancer burden. I am delighted to sit right next to a representative of the ministry. I mean, once you have the ministry in the house, then you're certain that beyond discussing just how cancer is deep in the global spectrum, right here in the country, then we have answers. And so Dr. Sultani Matendechero is right next to me. He is a senior deputy director at the Ministry of Health. Asante sana Daktari for creating time to be with us this evening. I know Kenyans are eagerly waiting to hear what the stats are like and where we stand, where we're positioned when it comes to dealing with cancer, and I'm sure you are ready and set to respond to those questions. We also are delighted to have Phoebe Ongadi, who is the Executive Director, Kenya Network of Cancer Organizations. Thank you so much, Phoebe, for creating time. Equally, of course, we depend so much so on the stats that you're going to accord us and the numbers that you're going to give us as to the cancer situation in the country. Right next to Phoebe is none other than Anne Korir. Anne Korir is the head Nairobi Cancer Registry and also senior research scientist, cancer epidemiologist, that is of course under KEMRI. Research is crucial to us addressing the concerns of cancer, and so we also want to understand, are we doing it right? Are we doing it wrong? Why is it that we keep complaining about the concerns of diagnosis and all that? And we, right next to Anne, we have none other than Dr. Onyiro Omondi, who's a lecturer at Department of Internal Medicine, University of Nairobi. Dr. Thank you so much for hosting us. Now that we are seated right here, Asante sana for creating time as well as we get to discuss some more as to the cancer burden in the country. And right next to Dr. is Professor Mansour Saleh, the chairperson, that is Department of Hematology, Oncology, Aga Khan University Hospital, right here in Nairobi. Asante sana for creating time. Asante sana. Kiswahili tuko sawa? We're good. Sawa kabisa.
Asema Swahili for sure.
Good. Asante sana. So on Saturday does not get you lost, Professor.
But
thank
not
you
your
so
kind
much.
of Swahili. My level is different.
Tutafanya rahisi.
All right. And of course, last but not least, Eunice Mwende, who's a cancer survivor with a beautiful story. And that is why we say that ultimately, beyond the troubles of cancer, there is hope. Perhaps to share your story briefly so that it can kick us to the conversation.
Thank you. Thank you so much for having me. My name is Eunice Mwende Mutiso. I'm 32 years old. I was first diagnosed with breast cancer when I was 23 years, and that was in 2016. So in our family, we don't have any history of any type of cancer. So, and I'm the youngest. So having a breast cancer diagnosis was really foreign, and we didn't quite understand what it entailed. So I had a mastectomy, which is removal of the whole breast, in the same year, 2016. Later on, then I was put on medication, tamoxifen, a tablet a day for 5 years. But unfortunately, after 3 years, I got a recurrence in 2019. So at that time, the cancer had spread to my lymph nodes and one of my lungs. And now that was metastatic breast cancer, which I better know it as stage 4 breast cancer. And I was informed that it is incurable. So what we started doing with the doctors who are handling my case was more of managing it so that it doesn't spread faster. So I was on, I did chemotherapy and targeted therapy from 2019 to around 2021, 2022, and because of the financial burden, I had to stop the treatment. So from 2022 March, I had to stop active treatment, but I was doing annual, checkups, scans to just see how it was. And in 2023, around September, when I did a full body PET scan, I had a recurrence, a nodule recurrence. So while I was in the process of now resuming my treatment, I got pregnant. So I didn't resume treatment, and I opted to have the baby. So my baby is 10 weeks at the moment.
Oh, beautiful.
And I'm here to share my story. So that is basically my story.
And people will be curious, you're breastfeeding. I mean, what happens? Just paint a picture of what then after the baby. Under meds, you stop the meds, or what exactly?
Okay, I'll take you a little bit back because we are also looking at the heaviness of this disease. So when I was diagnosed in 2016 and I had a mastectomy, it was really challenging for me. Being a young woman and having one breast, I actually didn't want anybody to talk about it outside our family. I would get really cross when that happened. And I got into depression for quite a number of months, actually about a year and a half. And at that time, I didn't know the importance of seeking therapy because this was also not pointed out to me when I was being diagnosed. And I felt that, that is one of the things we need to really be keen on when we are being diagnosed. When patients are being diagnosed, it's important and it's key to have now, the therapy. And so I had depression, and then I came out of it and I looked at life a bit differently, and I learned how to, a different definition of beauty, not just the physical beauty. And so by the time I was being diagnosed in 2019, I had already come into terms, with the first diagnosis. But of course, no one can you can't be ready to be diagnosed with stage 4 this was a day before my 27th birthday, and my prognosis at that time was 1 year. So again, that was a big blow for me. I had just resumed university, and at that time I had to choose both diagnoses. Actually, I had to choose between school and seeking treatment. So again, I sought treatment, and I had to stop schooling, it was a bit of a tough decision because I've always wanted to pursue my degree in psychology and counseling. So that was a tough one for me, and I resumed therapy. I got into different support groups, and one of the support groups I joined is called Kilele Health Association. It's made up of cancer survivors and caregivers. So through this organization, looking at now survivorship, we were hiking together, coming together, and that is something which gave me hope in terms of seeing that there is life beyond a cancer diagnosis. So I have hiked with them. We've climbed Mount Kenya, we've climbed Mount Kilimanjaro with this prognosis, and this also shows you that again, life doesn't need to end after this. So after, and when I now got this second diagnosis, the option of having a baby, it was not in my reach anymore, because one of the things I was already advised even before starting treatment it was after starting treatment, after my second chemotherapy. That's when I realized I needed to actually ask about fertility and having children, because I didn't have any. And at that time, my oncologist, we had not discussed this, which I feel, again, it's a huge topic we need to discuss before starting treatment. So that's when I was told about, egg harvesting and seeking, just going to, check the cost of this. It was, again, beyond me. I could not even afford it. So I just continued with the treatment, knowing that the chances of me ever having a biological child were not there anymore. So having a baby is also a miracle for me, honestly. And and when I got now pregnant, as I mentioned, I was in the process of now resuming treatment. We had quite a tough conversation with my oncologist. I have to say I am blessed to have an oncologist who listens. And she told me of the pros and cons of being pregnant, the chances of the progression of this cancer if I decide to continue with having the, keeping the pregnancy. She also mentioned, told me how I would probably need to start chemotherapy while still pregnant after the first trimester. So these are some of the things I needed to consider when I was making this decision. And gladly and, gratefully, I didn't have to do treatment while I was pregnant. But again, it's something which I need to go back and continue. So in terms of breastfeeding, I am breastfeeding, and I haven't resumed treatment yet, but I have to say I am really grateful that health-wise and physically I am doing well.
Congratulations for baby.
Thank
That's what I love when you go back home. All right. You got a beautiful story, yeah?
Bila shaka, na ni vizuri tukuongere kwa sababu wewe umejitokeza, ikiwa ni wakati ambapo tunazungumzia masuala haya. Hongera sana kwa kujitokeza na kuwapa wale wengine wako pale nje ule mwanga wa matumaini kwamba mambo haya yanawezekana, na vile vile tunaweza pambana na kupigana na saratani. Safi. Hivi sasa, mtazamaji, tuangazie kingine, na hivi sasa namkaribisha Daktari Sultan Matendechero kutoka Wizara ya Afya, ambaye ni katibu ama ni naibu mkurugenzi katika wizara hiyo. Daktari, najua kuna wengi wanataka kujua hali halisi ya masuala ya saratani humu nchini. Kutoka kwa wizara, tunaendeleaje katika kupambana na saratani humu nchini?
Asante sana kwa kunialika katika mazungumzo haya muhimu. Kile ambacho ningependa kusema ni kwamba kutoka kwa Wizara ya Afya tumeweka mikakati kabambe ya kuweza kushughulikia mambo ya saratani. Jinsi unavyojua, kwa Wizara ya Afya majukumu yetu, jukumu kubwa kabisa ni kuweza kuweka sera, zile policies, pamoja na zile guidelines za kuweza kutibu ama kuweza kufanya ile screening. Kwa hivyo tumeweza kuweka kadhaa. Utaniruhusu nizungumze kwa Kimombo, najua huwa tunazungumza kwa Kiswahili, lakini sasa hapa naona Kiswahili kitakuwa kigumu kidogo. Kwa hivyo, just to maybe name some of the policies that we've put in place to be able to guide management of cancer. We have the National Cancer Treatment Protocols that came into place in 2019. We have the National Cancer Screening Guidelines of 2024. We also have the National Cancer Control Strategy 2023 for a 5-year period up to 2027. So that's what we are now implementing. We also have a National Cancer Policy, which now is actually giving rise to most of these documents that we are talking about. That is spanning from 2019 to 2030. Now remember, our main aim is to actually be able to reduce the number of new infections by about to about a third by 2030, and we also have a breast cancer action plan, because breast cancer, as you've heard, and by the way, I really get encouraged when I hear stories like Mwende's story, which really give a lot of hope to many of the people, victims, who are affected by this very big problem. So we have an action plan just geared towards breast cancer, running between 2021 and 2025. So maybe just to say that actually cancer is one of the biggest public health problems in Kenya. Actually it ranks very highly. When you combine all the infectious diseases, actually now it comes a close third, because when you do all the infectious diseases, they come top. Then we have the cardiovascular diseases, and then we have cancer. So it is a very big problem, claiming thousands of lives every year. I know that we will I'll give an opportunity for others to put in the statistics, but it is a very, very big problem. We are having very many new cases, very many unacceptably high number of deaths globally, within the Africa region, within Kenya. It is something that we really have to pay a lot of attention to. Now, just so that I can also conclude and give some time to my other panelists, fellow panelists, to say something. What I'd just like to say is that we have now started rolling out a very big policy in the country around, very ambitious, by the way, to try and make sure that we are rolling out universal health coverage. And what we mean by universal health coverage is that each and every Kenyan who, is able to access high quality care, medical care, at an affordable cost. Yeah? And that is a very ambitious plan, because I'm saying this on this World Cancer Day, because the cost of treating cancer is unaffordable to most people. So that becomes one of the specific areas that we are targeting, to say even those who require lots and lots of money to be able to manage cancer then should be able to get treatment. But at the bottom line of this policy, we are saying that we want to prevent a situation where people will require to use a lot of money. So we are putting a lot of emphasis on health promotion and disease prevention, so that we minimize the numbers of people who need treatment, that expensive treatment. We are focusing more on screening, so that we detect cancer early, and then we are able to manage. Because when we get it early, and I know a lot of the panelists here will really expand on that, then even the chances of treatment are increased, as opposed to when we now get it much later, then we find that it becomes more difficult for us to achieve good outcomes in terms of treatment. No. So as a government, we are on the front line to ensure that we actually put this problem under control, so that we reduce the numbers and we have much more effective outcomes in terms of detection and treatment. No. Thank you.
Shukran sana Daktari Sultani Matendechero, ambaye ni naibu mkurugenzi mkuu kutoka Wizara ya Afya. Na mtazamaji, hivi sasa tunaendelea pia na maswali kuweza kupata washikadau wanasemaje na vile vile wataalam, na tungependa kujua, nikizungumza na daktari ambaye ni Daktari Mansur Saleh. Hivi sasa tunazungumzia aina tofauti za saratani. Labda ni saratani zipi ambazo zimeonekana kuwa hatari zaidi humu nchini?
You know, I was born in Zanzibar. I used to speak Swahili very well, but you are beyond my level of comprehension. Even the ministry had to change to English, so you have to. I understood you're calling me out, but go ahead and ask me the question in English.
The most common cancers that we have, and perhaps I'll need to top up to his question as to what it is that the DG speaks of, or the Deputy DG speaks of, in relation to the possibility of us reducing the burden in terms of treatment prices, in the country? Because then this is not the first time we're discussing this, and I know we progressively get somewhere, but do you realistically think that as a country we are well positioned, first of all, to address this concern in terms of treatment and the prices that come along with that, but as well in terms of just detecting and perhaps avoiding this? Because then we're also saying that we are focusing much on preventive care more than that level where it gets to curative.
It is fair to say that the government makes policy. The people have to implement policy, and then in between we have to facilitate. We just heard to say that the care was expensive, beyond my reach. So if the government makes policy to say we will have mammography for breast cancer, colonoscopy for colon cancer, and pap smear for cervical cancer, but if it's very expensive, then that policy cannot be implemented to reduce the burden of care. But also it depends upon the population itself. What is our level of knowledge about cancer? 1 in 30 women will develop breast cancer. 1 in 35 will develop cervical cancer. 1 in 10 population, and we see here we've got about 100, 1 in 10 will die of cancer down the road. So what do we know about cancer? We know that the most common cancer in Kenya is breast cancer. The only way to detect it early is mammography. So I believe the policies of the government should allow mammography to be cheaper so that we can detect it early. And then we can prevent it, not prevent it, but at least detect it early, stage 1, stage 2. Patient can be cured and have a productive life, pay taxes. So really it benefits everybody. What about pap smear? The best way to eradicate cervical cancer is vaccination. Cervical cancer is caused by the HPV virus. We vaccinated ourselves against COVID. Otherwise, we were dying. What about cervical cancer? If we did vaccinate our children at the young age, 98% of cervical cancer would be eradicated. Well, we have not reached that stage because there's all kinds of social controversies about vaccinating against cervical cancer. So I think what we need to do as a population, look at new knowledge, to be able to really implement that knowledge, and then certainly the government can do their part to facilitate, to make these applications much cheaper, affordable for the patient who needs them the most.
All right, pretty much good. I think that brings us to the research bit. Then we'll come back to you, of course, to get to understand that element of diagnosis that you have highlighted. But basically, when we're looking at this, and the research ladies are here seated, and one would want to ask at this very point, Kebri, just how much has the government been serviced, by backed up research information that is good enough to help them, first of all, come up with policies that are practical, but above everything, proceed to help implement these policies?
Thank you. So research is key in terms of cancer control, because we need to be able to come up with interventions to be able to control these malignancies. I would say that KEMRI for the longest time was more focused on infectious diseases. But of course we do research on non-communicable diseases, cancer included. One of the key things we invested in early, way back in the year 2000 about cancer, was to really understand the burden, to understand what is affecting our people. So we invested in establishing a cancer registry that has been in existence for over 20 years. So we were able to tell the cancers that are prevalent in the community, which ones are going up, which ones are going down, what then would inform research or putting in more resources. So for instance, when we look at women, we have data that supports that breast cancer and cervical cancer are the two cancers that are killing our women. We have data on incidence, we have data on mortality, we have data on survival. And you realize that we are diagnosing these women at a late stage. What happens when you diagnose them at a late stage, stage 3, stage 4? It means that there are poor outcomes. Many women are dying of these diseases. So the question then should be, why are they being diagnosed late? Is it them coming to the facility late, or is it our health system that is failing them? We've also seen, of course, cancers that are also common in the men population, like prostate cancer, esophageal cancer. We are seeing colorectal cancer now coming up, both in men and women. esophageal cancer as well, very common in women. So you're having this double burden of cancers affecting the women, but overall, 40% of the cancers in women are breast and cervix. And as you've heard from Daktari, these cancers are preventable and they can be managed. We shouldn't be losing so many women to these cancers. Why? Because if we vaccinate, if we screen, then we are able to overcome cervical cancer. For breast cancer as well, if we did screening with mammography, we are able to diagnose them early and be able to treat. When you diagnose at stage 1, stage 2, survival from our research is very high. People survive 90% and above when they are diagnosed at stage 1, stage 2. But the unfortunate situation is that our data is showing that we are diagnosing them at stage 3, stage 4, when we know very well that the treatment, even as much as the doctors are trying, the treatment then become less effective. So we are doing research. Of course, there are other research beyond the surveillance that we are doing on cancer. There's lab research that looks into diagnostics. There's molecular research. There's research that looks at the genes, in relation to cancer. There's research that looks into the risk factors to isolate what are the risk factors that are really predisposing these cancers. But I want to say that funding for research is still very limited in our country. We really need to invest in research. We have not invested adequately in research, in funding research that is affecting our people. We over-rely on donor funding, and when you over-rely on donor funding, then you don't really get to be in control of the agenda. So we need government to put in funding for research so that we can be able to do more and be able to really come up with more intervention, more ways of diagnosing these cancers early, better therapeutic ways so that we can manage the cancers that are being diagnosed in the population.
We're glad that the government is here tonight, and so I hope the government is taking note. But then before you come in with Phoebe, briefly, Daktari, Professor acknowledges that there's knowledge gap. Perhaps there's a concern when it comes to the question of of education. Just how critical would it be in terms of enlightening the masses, the element of education? And we also understand that research goes hand in hand with that element of education. So that if we get the most and the best of data from the research that we collect, and this is not disseminated to the public for use, then it becomes useless. That if we're going to form the best of policies, at that level of the government, but this then is not known and is not consumed by the masses, it becomes a problem. How do we go about this to address the same so that we all are in tandem towards this fight?
Thank you very much. This year the theme is, I think, united in uniqueness, and listening to her story, what united in uniqueness means is that every cancer patient has a personal journey with their cancer management and just living through the cancer diagnosis. But some people have misconstrued this to mean that each patient care is now unique, but there are certain aspects of care that cannot be unique, like quality of care, Dr. Matendechero. This must be universal, and every attempt should be made to make quality care, safety of that care, access and readiness of the system to cancer care universal. And I'm glad you're saying we are rolling out universal care. Number two is about the challenges that we face as a country in this cancer journey. And one of it that you've alluded to is awareness of the population about cancer services, which is quite low. If you look at surveys that have been done in Kenya, if you look at the Kenya Health Facilities Assessment and some of the vital documents in the Ministry of Health, awareness is quite poor, and this has been one of the reasons for either late presentation to health facilities, and that means that we are diagnosing our cancer cases at an advanced stage. I think 3-4 years ago, 80% of cancer diagnosis in Kenya was at an advanced stage. But I'm glad to report that has been reducing, and one of the interventions was health education, so that people are aware of the signs and symptoms of cancer, where to get this cancer services, the need to do early diagnosis, and this is really important for the citizenry to also know where those services are. Now, there's a lot of research that is going on even at the University of Nairobi. And one challenge that we have as researchers is communication to the public, you know, how to convert the scientific information to the public. For example, if you say the overall survival of a particular disease is 60% at 5 years, for us, we understand this amongst ourselves. But the assumption we make is that the population is going to digest it the same way. So translation of scientific information to non-scientific or to lay people has been a big challenge. And I think the ministry, when you go through some of the strategic documents that the ministry is a very ambitious process for health education, you know, reaching out to the public through primary health care, and the refurbished Social Health Act has a primary care arm, which is meant to reach 80% of the population. If you read the Kenya Health Facilities Assessment, 80% of which is level 1, 2, 3, you look at the first of all cancer services in those health facilities in terms of screening, because that is where you need to take screening services. If you bring screening services to Kenyatta National Hospital, it should be there, yes, but if there's no screening services at the health center, you expect somebody to leave a rural village in Kiambu or Murang'a or Siaya to come for cervical cancer screening at the Kenyatta National Hospital. I think you obviously see there's a big challenge to that. So with the lack of those screening services in those primary health facilities, then the population around that health facility will not get access to cancer education. So I think one thing that we need to do as scientists, we need to convert the scientific information that is, for example, the University of Nairobi repository is very rich with the studies that have been done on cancer. But how this is translated so that the public can understand that when you have this symptom, for example, if you have constipation, and there is this common treatment which is H. pylori, you find everybody we see who eventually make a diagnosis of cancer, a big percentage has been treated H. pylori. And the way the population understands the H. pylori treatment, I wish they could get the same message about breast cancer screening. Because some people come and demand, I need H. pylori treatment. I wish that we can employ the same strategy that people who marketed the H. pylori kits used to educate the public, so that somebody can make a conscious decision to go to the hospital to have H. pylori treatment. If we can get that strategy so that somebody can make a conscious decision and say, I want to go and have my mammogram, I want to go and have my annual cervical screening. Thank you.
Asante sana daktari kwa kauli yako, na hivi sasa tumshirikishe Phoebe Ongadi ambaye ni mkurugenzi mkuu wa shirika la Kenco, mashirika ambayo yameletwa pamoja kuangazia masuala, na ulivyozungumzia tiba na vile vile ya saratani, ni muhimu zaidi tuweze kujua ni vipi masuala haya yanashirikishwa na mashirika haya ili kuweza kuhakikisha wagonjwa wanapata tiba kwa wakati. Phoebe, mnafanya vipi kuhakikisha mzigo huu wa tiba ya saratani unapungua?
Asante sana, nimeshukuru na nimefurahi sana kuona Wizara ya Afya karibu na mimi hapa. Najua suluhisho zangu zote za SHA nikitoka hapa nitapata majibu ambayo yametuzuia kidogo kama cancer fraternity. 30% na 50% za kesi za saratani zinaweza kuzuiliwa. Hapo ndio tuanzie kama Kenco. A third and half of cancers can be prevented. Na kwa hivyo jambo la kwanza ambalo tunafanya kama KENCO ni kufanya ile uhamasisho ama public education and awareness. Tunapata kwamba why we have late diagnosis, ama kwa nini wagonjwa wengi wanakuja wakati ambapo saratani imeenea zaidi, ni kwa vile hawajui, hawana ule ujumbe. Na niseme tu kidogo, Eunice ambaye amekaa hapa ako na taji, anafaa awe alitembea nayo, taji ya Scars to Stars. Pale KENCO pia we celebrate. So last year she won, heavily pregnant, down the L. She was able to win. I think she deserves a hand of a clap for that. So we leverage on public kuhamasisha jamii. Kitu ya pili ambayo tunafanya ni kuwa tunajaribu kutafuta zile policies ambazo zinasaidia. Vile nimesema, maneno ya SHA kwa karatasi ni mzuri sana, lakini tunataka sasa itoke kwa karatasi kuje kwenye mashinani iweze kufanyika zaidi. Pia tunafanya ile inaitwa kwamba most of wanachama wengi wa KENCO ama most of KENCO members wana ile inaitwa patient led. Kwa hivyo ile patient led tukitembea na wagonjwa pamoja na zile stories zao ama patient stories zote, tuniongee na kimombo. We have the patient led organization. So when we have those, we also do a lot of psychosocial support. Like Eunice and many other people told you, when they're in a group, when talk patients together and they share their stories together, it's a bit different. So KENCO also, together with our membership organizations, we also participate in the enactment of the 2012 Cancer Prevention and Control Act, and that is what brought up the National Cancer Institute that is currently doing the implementation of what was Kurugenzi said of the strategic plan for 2023-2027. So I ndio maneno a few of the interventions that we are doing as a group and also as individuals.
Shukran sana. Hivi sasa tumshirikishe mwenzetu mtazamaji ambaye ni Sheila Chelangat ambaye anatangamana na hadhira. Sheila, hadhira inasemaje kuhusiana na swala hili? Tusikie hisia zao pia.
Indeed, Josh Onsare, we are listening to the experts speak about, sensitization, being that today was World Cancer Day. So it's all about sensitization, uhamasisho, that is what I have had. But does this public, does this audience really understand what it means by sensitization? Do they understand? Are they aware of some of the signs and symptoms? Are they aware of some of this research? And so with me here is Paul Nganga. You are a patient who is undergoing treatment. What are some of the signs and symptoms that perhaps you noted before going in for treatment and seeking for that diagnosis?
Thank you very much. For the first time, what I noticed in my body was hemorrhoids. But I didn't know that they'll come with cancer. Then I went to Kiambu Level 5 for treatment. After surgery, that's when the doctor did the biopsy. I was sent to Aga Khan Medical. They say that I have those symptoms of cancer. Then I was referred to KNH for treatment, but I was sent to SOPC, not to oncology. Then after that, they did physical examination for, I'll try to be brief because of their time. They did physical examination and told me that they don't see any problem that I have. So I was sent home and told whenever that I have any problem to go back to KNH. Then I stayed for about 3 years with a lot of pain, and I was taking drugs for painkiller. I went to Mama Lucy again for treatment. I went to Kenyatta. They told me go to Mama Lucy. You cannot be treated here without referral letter. So when I went to Mama Lucy, they did the operation again and told me that they have found what they were not expecting. So they told me to bring all the papers that I obtained from Kiambu Level 5 and all the CT scan and MRI colonoscopies that I got from German hospital. Then when he compared them, he told me that the problem that they have seen, it is similar. So I was sent to oncology at KNH.
And so far, as in this journey of your treatment, what would you say is that challenge that you have faced majorly?
Concerning treatment?
Yes, concerning treatment.
Okay, concerning treatment, the major problem is when you go for MRI, colonoscopy, all those, the insurance used to cover almost 3/4. It was not able to cover everything. Then when you go to KNH for consultation, you have to pay cash. So the insurance cover does not pay for cash for consultation. And even when you go for blood works, you have to pay cash. But the doctors there, they have time for you, they listen to you, they are very caring. But again, the bigger challenge that we have there is that after seeing the doctor, when you are sent for chemo, you find there are no drugs. So you go to another hospital.
All right. Those are some of the challenges and the realities of cancer, and that we are hearing from a patient who is currently undergoing treatment. But it's not just about now the treatment. There are some who have undergone the diagnosis but are yet to start the treatment. So why is that? Let's get to hear from Jacqueline. Hujambo, labda utueleze tu story yako. Uliweza kujuaje una kansa na mbona kufikia sasa hujaanza treatment yako?
Kitu naweza sema ni venye nilijua niko na kansa. Sikujua, nilienda nilikuwa na infections zilikuwa zinanisumbua sana, so nikaamua kwenda hospitali niangalie kwa nini hizi infections zinanisumbua. Wakiniangalia wanaona ni UTI, kila time UTI. So nikaamua kwenda kwa hospitali zingine na ingine, nikiangalia wananiambia tu ni infection, wananipatia dawa za kuinsert na za kumeza. So niliendelea tu hivyo, nikaamua niende Bagavi nifanye testi zote. Nikaenda Bagavi nikafanya test, nikasema wacha nifanye kila kitu. Nikafanya pap smear, nikafanya test za mkojo, kila kitu. So nikaambiwa mbona ulikaa hivyo mpaka hii ugonjwa imeenda mbali hivyo. So ile kitu ilikuwa imenipatia surprise.
It is the reality, the sad reality that, you know, she's even shedding tears. Are you able to continue with your story?
Yeah.
Okay.
So venye nilienda, nilikuwa nimeshafanywa screening before. Nikaambiwa niko na cells na wakaniambia wameniweka dawa. Hiyo story ya niko sawa.
Endelea tu.
Nikaambiwa niko sawa, so daktari akuniambia nafaa nirudi after 6 weeks niangaliwe tena. So venye nilienda Bagavi, daktari aliniambia mbona umekaa hivyo, mbona hukurudi after 6 weeks? Nikamwambia mimi sijui. So ndio daktari akaniambia ninaona tufanye hizi test juu naona ni kama uko na cancer. So wakanifanyia pap smear, wakaniambia nipeleke Dr. Plaza. After 1 week nikaendea results, nikarudisha. So wakaniambia ati kesi yangu lazima niende clinic 18. So after 18 kuna daktari akaniambia gyno. Kuna gyno akaniambia niende nifanye MRI. Kwangu kufanya MRI imekuwa ni challenge kwangu juu sikukuwa na hiyo pesa. Nikienda kila mahali wananiambia 37,000, 31. So nikachoose penye ilikuwa ni cheaper, nikaenda kwa 31. So ili take time kabla nirudishe hiyo result ya MRI. So kurudisha result ya MRI ndo wakaniambia kulikuwa na hii time holiday ilitokea from nowhere. So kurudi tena daktari akaniambia niende nifanye CT scan. Bado CT scan ilikuwa ni challenge kwangu juu kurudi nilienda Germany wakaniambia wachukuisha. So nikachanganyikiwa. So ikabidi niende KU penye nilifanyia MRI nikafanya CT scan.
Okay, asante sana Jacqueline kwa story yako, and thank you for being courageous to share the story. One thing that you can note from both stories, it's about the cost of treating cancer. And before that, let me take you to our studio with Liz Mutuku, who will take us to Mombasa. Liz Mutuku, over to you.
Naam, asante sana Sheila Chelangat na timu yote kutoka upande huo wa Chandaria katika chuo kikuu cha Nairobi, ambapo mjadala huu wa kikao unanoga kuhusiana na swala la saratani, siku ambayo tunaendelea kusherehekea na kujijuza mengi kuhusiana na ugonjwa wa saratani, lakini mzigo wake siku zote unasalia changamoto, sio kwa umoja bali kwa wengi katika taifa hili la Kenya. Nitakuwa nikizungumza na Daktari Pukose ambaye ni mwenyekiti wa kamati ya afya bungeni kuhusiana na mzigo huu, matibabu yenyewe na baadhi ya yale ambayo wameweka kama bunge kuhakikisha kuwa Wakenya wanafaidika na kusaidika. Lakini kwa sasa tunawapisha wahisani wetu.